Yeah. Hello all. I invite you to the talk on interpretation of chest radiograph. Good evening, all the listeners, all the e-listeners. Let's go ahead. Okay, the chest radiograph is one of the frequently ordered nations. Chest radiograph is one of the frequently ordered radiographic examinations in children as well as adults. Hence, the accurate interpretation is very important for administering appropriate therapy. So, for that, you have to. There is a systematic way of interpreting the chest X-ray. It goes like this. This is a suggested scheme. First, in the topmost is the patient demographics. First, you have to ensure that you are reading the right person's radiograph. You have to check the side marker, the right left side markers, and the date. Make sure you're reading the current examination, and then if the priors are available, always compare. It's really of great use. Comparing with the old radiograph, it will solve a lot of problems. So that's about the patient demographics. Let's move on to the technical factors. Usually, the commonly done the examination is the PA view, usually PA view, and it is obtained with the patient in standing position, facing the cassette or the image capture device. In case of these DR systems, where the image is directly acquired onto those capture devices. Conventionally, we have this X-ray films loaded into the cassettes, placed in the holders, and then exposures, X-ray exposure. Then it needs to be developed in the dark room. Nowadays it's not that commonly used. Most of them are either CR computer CR. They are called CR radiography, or in a tertiary care centers. Usually they are DR systems. So it's done with the distance between the tube and the X-ray is around 6 feet. That's the standard. That's the standard PA view. How it is done, and sorry, it's not moving. Okay. Next, the other factors are the centering. The patient need to be centered to the cassette or the image capture device, and then there are ways to determine how well it is centered, and then the markers. You have to place the markers on the cassettes or the this capture devices, right? And here are the some of the examples of the image on the left was done with a low exposure factor. That means using low kV, say around less than 60 kV. You see, it's all it shows the lung details are well seen on this, but however the other details, it's not very appealing. You may miss some. If there's anything in the retrocardiac region, you may miss it. Okay. Then the image on the right, where it is done at a high exposure, say something like 120 kV or so, where the lungs are burnt out. They look really black, and you cannot really see much in the lungs. But whereas you can see the other structures like osseous structures and all. So it has to be between these two, and depending on the indication. So a perfect radiograph should look like this. See how beautiful it looks with everything being displayed. You can see the lung markings very well. You can see all the rib cage, diaphragms, everything fantastically depicted. Okay, and then here the centering is about the patient. If the patient is well centered, you can see this. I will use this highlighter. can see this. These are the transverse processes, and that's your medial end of the clavicle. That it should be equidistant. Otherwise, if the patient is rotated, say right or left rotation, the cardiac size may look larger. I mean, spuriously large. Hence, the centering is very important. You have to make sure that the patient is centered in accurate position. Next comes the same thing. It's in a diagrammatic representation. Those are the transverse process. The spinous process, and this the medial end of it. They should be equidistant. This distance should be the same. Then you get the that's the accurate centering. Next, look for the trachea. So I'll start from in a systematic way. Start with trachea. After all these demographics and the technical factors, make note of all that, and then move on to the actual interpretation. Trachea first. Look for the, see how it looks. Look for the narrowing. That's the lucence. You can see this lucency here. That is the tracheal shadow. Look for any narrowing, displacement. You can see this is a carina here. Any widening of the carina. Make observation of that. Normally, if the radiograph is done in, usually it is done in good inspiration. If it is done, say, patient cannot hold breath or not able to follow the instructions, in expiratory view, there may be some bulging or kink of the trachea to the right. That is normal. Whereas in a good inspiratory view, you see there is a deviation to one side. Further interrogation is required for that. And then next move on to the heart and mediastinum. Once the trachea is over, then move on to the mediastinum, heart and mediastinum. Commonly, the structures that form the borders of the mediastinum on the right, in the superior portion of the right, there comes the innominate artery, and then that follows the superior vena cava, and then in some parts, a portion of the ascending aorta will also form the right heart border. Further down, this is the right heart border. These all form the right mediastinum borders. On the left, this is the aortic arch, aortic knuckle it is called. Cranial to this is usually the subclavian artery or innominate veins form that part, and that is the aortic arch. And followed by, this is your pulmonary bay. Okay, and then the left heart border is formed predominantly by the left ventricle. And then you can see in the background, this is an elderly patient. You can see the aorta, descending thoracic aorta can also be seen if it has unfolded. Even here, there's a little bit of unfolding here. That's why we are able to see this the ascending aorta very well. Right. Now the cardiac anatomy, what constitutes these borders. You can see the right heart border, the SVC, and then predominantly the lower right heart border is predominantly found by the right atrium. The right ventricle is not depicted on the AP radiograph. So it's anterior, hence we do not see it. Unless it is enlarged, we cannot make that out. The left heart border is found by the left ventricle, and the heart apex is found by the left ventricular apex. And you can see the pulmonary artery. That's where the pulmonary bay was there. Okay, corresponding cardiac anatomy. Next, let's move on to this measurement of this cardiothoracic ratio. This is very important for the radiologist. Hence, how it is measured. I mean, you must be aware most of them. It goes like this. You draw a line, the midline on this spinous processes. Take the maximum diameter onto the right and to the left. Add these two, or you can actually take this diameter, measure it, and then you have the other measurement you have to take is the maximum inner diameter, right? And then that ratio is C1 C2 by 2T. That is the inner transverse thoracic diameter will give you the cardiothoracic ratio into 100. Usually it should not exceed 50 to 55% in Caucasians. It is up to 55. It is normal up to 55% in other races. In neonates, you got to be very careful here. Up to 60%. Don't overcall them unless it is real cardiomegaly. Do not call cardiomegaly on the neonates, because up to 60% is normal for them. So in the maximum transverse diameter of the heart in men is around 16 centimeters and 15 in women. This helps in comparison. So whenever there is when you are comparing radiographs, the interval difference of 2 centimeters increase in diameter is significant, when originally it was normal. Whereas in enlarged hearts, much less change is significant. So you have to keep this in mind. The maximum diameter of the 16 and 15, these are also very important. I mean, say this is that maximum transverse diameter. So this will help. And one more point is from the midline, if you see this diameter should be less than 5.5. I mean, anything above 5.5, okay, anything above 5.5 is that right atrial enlargement. Okay, let's move on to the next one, the hila. Once the mediastinum, you have to look for the widening of the mediastinum also. This is the one. Usually we take it as 5 centimeters. If it is more than 5, this is on a PA radiograph. Mind you, all these measurements change on AP view, right? The AP views are usually not done routinely, only in when patient cannot stand, debilitated, or in the ICUs. These AP views are done. So always look for this this mediastinal widening. You have to allow for on AP radiographs. There will be, in fact, this will be exaggerated because of the positioning of the cassette. There will be some magnification of the heart and the mediastinum. Hence, you have to allow a little more than 5 centimeters. Sorry. So let's move on to the hila, the next part. The hila, left hilum is always higher than the right, and they should be of same density, and they should have clear defined lateral borders. And what constitutes this is the inferior pulmonary artery, in fact, and that is your upper lobe pulmonary veins. These two form the hilum, in fact. So pulmonary arteries and upper lobe veins contribute to the hilar shoulders. So left pulmonary artery lies above the left main bronchus. Okay, it goes above the main bronchus, hence always higher until unless there is a pathology in the lower lobe that pulls it down. And the left pulmonary artery lies anterior to the left main bronchus. Okay, again the right pulmonary artery, hence it is lower. The diameter of the normal pulmonary artery is 10 to 16 mm in males and 9 to 15 in females. See, it has to be measured in the mid pulmonary artery level. It should not exceed that diameters. Those are useful in calling it as for determining the pulmonary arterial hypertension. And then the arrangement of the veins and arteries in the upper lobes. The veins lie lateral to the arteries, whereas in the lower lobes they lie medial to the arteries. Here you can see this is the. I'm going to remove all this. Okay, that is the pulmonary artery, and whereas you can see in the lower lobe they are medial. They are medial. You can see this. There's a branch here that goes in. Okay, those are the pulmonary veins. They are medial in the lower lobes, whereas they are lateral on the upper lobes. The location of the pulmonary veins. And one more important thing is at the first intercostal space, the upper lobe vessel. So let it be artery or vein. This is the first intercostal space. It should not exceed 3 mm. It should not. The diameter of the vessel should not exceed 3 mm. So whenever there is increased, that is cephalization, pulmonary venous hypertension or cephalization can be called, right? And then whereas the arteries accompany the bronchi in the interstitium, you can see the though you cannot see the interstitium on the radiograph, the arteries and bronchi go together. whereas the veins, they drain through the interlobular septa. So that's about the hila. And the bronchial vessels, usually they're not seen on the radiographs because they're not seen because of their location. They usually arise from the ventral descending thoracic aorta at T5 or T5, T6 level. Usually 2 on the left and 1 on the right, and this is highly variable. And then these enlarged bronchial arteries, in case of this congenital heart disease, may appear as small nodules around the hila. So that you have to, once you know the patient has got congenital heart disease, look for these collaterals around the hilar shadows. Okay, right. The next, move on to the diaphragms. Usually the right diaphragm, this is how it looks. The right diaphragm is higher. Right diaphragm is higher than the left. This is what is commonly seen. And then in small percentage of population, the left is higher. And if the difference between the 2 domes of the diaphragm is more than 3 centimeters, then it is significant. Always, when you're on a PA radiograph, look for the free air under the domes of diaphragm. If you look in these regions, that's the gastric bubble. Okay, right? And then that is about the diaphragms. And next, move on to the fissures. The lung fissures, we have one oblique and one major and one minor fissure on the right, and whereas on the left we got only one oblique fissure. So these fissures are usually not seen on the frontal radiographs or PA radiographs because of the angle the angle they are located. They are not for any fissure to be visualized on the frontal radiograph. They should be perpendicular to the beam of the to the X-ray beam. Then only sometimes we do see this minor fissure on the right side. More so when there is pathology in the upper lobes, and then arching of the fissures can be picked up, or sometimes when there is pleural effusion, it gets tracked to the minor fissure and they appear lenticular shape. On the lateral radiograph, you can see this major fissure starts, say, 5 centimeters anterior to the anterior border of the sternum, and then it takes oblique course, whereas the minor fissure, you can see it's only on the right side. It's only on the right, and that the lung between this minor and major fissures this is the middle lobe. Whereas on the left side, you can see only one fissure, so not much confusion. So then let's move on to the costophrenic angles. You can see this on the anterior view. You can see this very sharp. That means there's no effusion. And then if you have lateral views, this posterior cardiophrenic sulcus, even if there's a very minimal fluid, it can be seen in this posterior costophrenic sulcus. So always look for as the patient, in the elderly patient, say suppose this CP angles are a little blunted because fat accumulation and then some flattening of the domes due to this hyperexpansion of the lungs. So always look for this cardiophrenic angles, especially the lateral, to pick up minimal effusion. And then if you observe, the right diaphragm is almost completely visualized, whereas a small portion of the left is not seen. That is because of the heart is sitting on this, and then the left diaphragm is always, when in majority of cases, it is lower because of the heart is sitting on that. Contrary to the notion that the liver that is located in the right upper quadrant pushes the right hemidiaphragm. That's not true. It's mainly because of the heart sitting and then depressing the diaphragm, the central portion of the diaphragm and left portion. Then move on to the lung fields. So always, you can follow a standard pattern. First, look at the lungs and move outside, or start from the center, trachea, mediastinum, heart, hila. Then look at the diaphragms, look at the CP angles. Then go to the lungs, and then this is the recommended pattern. You have to sweep through the lungs in a systematic fashion, so that you should not leave out any portion of the lung. And then you should always compare for the compare with the opposite side for any change in pattern. So that comparison really helps. I mean, comparing it to the opposite side, opposite lung. So always follow a pattern, examine each and every part of the lung so that you do not miss out small nodules or any abnormality. So it will be good practice, to carefully observe for the lung fields in a systematic way. Do it from the top and then start again from the lower part and then go up again. Do it a couple of times so that you don't miss out any of the lung field. And always look for the translucency in the lungs, whether it is symmetric or asymmetrical, and uneven distribution of the lung markings. You have to make note of that. Any abnormal shadow to be further interrogated. Sometimes these normal structures, when they overlap, especially at the lung apices, the ribs and the they make the normal structures look abnormal. So you have to carefully look for that. Make sure you're not missing out anything there. So the next, the lung segments. To pick up the pathology in the lungs, you can see here the lung segments: upper, middle, and lower lobes. On the right, you have 10 segments. On the left, you have 8 segments. Only difference is that on the left, the apical and posterior segments, it's a single segment, and then in the lower lobe, left lower lobe, instead of anterior and medial basal individual segments, you have anterior medial basal single segment. So each segment will have its own bronchus, the pulmonary artery branch, and then whereas in the middle lobe you have this medial and lateral segments, and in the lingula the superior and inferior. So to make note of this, otherwise they're pretty much the same on both sides. And then this is the diagrammatic representation of the segments on the AP view. Say if you're looking on the AP view, most of the anterior part in the upper lobe. This is the pink or violet. This is the anterior segment of the right upper lobe. This blue one is the anterior segment of the left upper lobe, and that is the apico-posterior segment on the left, and that is the apical segment on the right. The small orange thing is that is the posterior segment. This is as seen on the anterior view, on the AP radiograph rather, and that is on the posterior radiograph. You will see most of it is formed by the lower lobes. In fact, see, very little part is formed by the upper lobe segment. You can see that's a little bit of anterior segment, and that's the posterior segment. This is on the left because of the reverse. This is the left lung, so left, and that is the right, because right. You can see that's the posterior segment, and that is the apical segment. Anterior segment is not seen here. On the left, you can see most of it is formed by the lower lobe, right? And there you have different segments, the diagrammatic representation, and then this is the right lateral and left lateral projections, and that is this is the medial lobe area, and that is your lingular area, and this is all lower lobe, and that's the upper lobe. Right here you can see that is the apical. This is right side, right apical segment. That's the posterior segment. That's anterior segment. Okay, let's move on. And then just a brief anatomy on the microscopic anatomy on this bronchus divisions. Actually, the main bronchus divides into 6 to 20 times before it becomes bronchioles. That means the terminal bronchiole. This is the terminal bronchiole, and this terminal bronchiole receives 2 or 3 respiratory bronchioles, and each respiratory bronchiole receives up to 2 to 11 alveolar ducts, and each duct has 2 to 6 alveolar sacs, and each sac is made up of thousands of alveoli. So this whole unit from this terminal bronchiole till this is called acinus. This forms when someone describes airspace opacity, they're talking about this, acinar opacities, alveolar opacity. This is the whole thing is the single acinus. This many, the terminal bronchioles, respiratory bronchioles, alveolar ducts, sacs. and then the alveoli form one single SNS, and there is a cross communication between these alveolar sacs. That's why you see this in a consolidated or atelectatic lung. You can see this air in totally collapsed parts of the lung. That's because of the drift from the one alveoli, between the alveoli, air drift between the alveoli. So that's a brief anatomy about the SNS. Now move on to this. Once this is done, go on to the hidden areas. So this is the lung apices where the lesions are commonly missed, and then the lateral aspects of the lungs, and then the costophrenic angles, costophrenic cell side, and on the lateral view, look for the lucency in the. I'll talk about this a little later. Look for the lucencies, retrocardiac and retrosternal lucencies, and look for the diagrams. Look for free air, and also look for the osseous structures, especially in pediatric population. Look for this rib fractures and all. And move on to this soft tissues. Once because once the rest of the areas are over, move on to soft tissue where you have to look for the breast shadows. When there is mastectomy, this can give rise to the increase in translucency in one lung. So hence it is important to look for the breast shadows in case of females, to look for any asymmetry or any mastectomy. Document that. And sometimes these nipple shadows are usually symmetric shadows in the lower lung zones. Don't confuse them for nodules. If there is doubt, so place a nipple markers and then repeat. And there's these skin folds, especially when the radiographs are done in oblique position. Say when the patient is not centered very well, you have these axillary folds, then the other skin folds that overlie the lung fields. Hence, you have to make note of them. And then companion shadows. You have, especially for the clavicles, you have companion shadows. I'll show that here. And see that. Yeah, I can see that that is the companion shadow there. So that those, make note of all that. And then to conclude, before concluding, you have to look for the subdiaphragmatic regions, right? And then that is look for free air. This is one of the most important indications. Patients land up with acute chest pain, and if you see they'll have a free air. So it's very important to look for all the regions of the chest X-ray, so that you're not missing out on anything. Look for the dilated bowel loops in the upper abdominal regions, and then sometimes you do see this interposition of bowel loops in the right upper quadrant. That is Chilaiditi syndrome. That is a normal finding. So always make note of these things, and then move on to this osseous structures. Interrogate each and every structure. Look for the sternum for any any abnormality. Look for the vertebrae. If you're able to see all the vertebrae, look for the height of each vertebrae, and then follow each and every rib and look for any fractures, any osteolytic lesions, any sclerotic lesions. On the lateral view, any compression of the decrease in height. You have to note for the decrease in height of these vertebrae, and then look for the sternum. So lateral view is best for the sternum, right? So, and then moving on to the lateral radiograph, how to interpret this lateral radiograph. So this you can see, observe this is the cardiac shadow here, right? And you can look for the diaphragm, domal diaphragms. This what is seen under these cardiac margins. This is the right dome, because the left dome, you can see from here on, the anterior part of the left dome is not visualized because the heart is sitting on that. Hence, that is obscured. The diaphragmatic margin is obscured. So look for this retrosternal space. This usually should not be more than 3 centimeters. In COPD patients, this will increase. The retrosternal lucency would increase. And then look for the retrocardiac space. Look for this space. If there's any opacity, that means and that is not seen. If that is not seen on the corresponding PA view, that means you're looking at some mediastinal mass. Even this space is filled up in case of anterior mediastinal masses, like say thymomas or any lymphoma. This space gets filled up, and also look for the, see this translucency as the caudally, as you move caudally, this translucency should increase. This is very important because sometimes any pathology in the lower lobes, say early pneumonitis kind of stuff, this is the only finding you would see on the lateral radiograph. So it's very important. And then follow this tracheal margins. Okay, and this round structure is the right upper lobe bronchus. This is the left upper lobe bronchus, and look for the cardiac size. I mean, if there is any cardiomegaly, more and more of the heart occupies this retrosternal space. The same way, if there is any enlargement of the left atrium and left ventricles, you'll see this encroachment of this retrocardiac space. And look for the diaphragmatic outlines, as I told, and then fissures. You have to observe for the fissures. Now, that is your retrosternal, that's the retrocardiac spaces, and then that corresponding cardiac anatomy. You can see most of this. Just let me go back. Yeah, this you can see here. There is a small fold. That's the IVC marking. And you can pick it up on if it is well done radiograph, and you will see this IVC entering into the right atrium, in fact. So that is the IVC corresponding anatomy. You can see this right ventricle is anterior, hence you do not see it unless it is enlarged. The same with the left ventricle, obviously it will show because the left heart border is found by the left ventricle, and then the left atrium is again concealed. You will not see this on the PA radiograph or AP radiograph because it is posterior, located posteriorly, hence you would not see it on AP unless it is enlarged. So some of the signs of this enlarged left atrium is, you may see this double atrial shadow, right heart border, one more border onto the right. I'll show that later. And then there may be carinal widening. You can observe this carinal widening. I'll show that later as well. And that is the aortic arch, right? And then let's move on to some of the important signs on the chest radiograph. If you look at the silhouette sign, there's one of the important signs called silhouette sign. That means this helps in localizing the lesions. Okay, by using this mediastinal diaphragmatic borders. These borders are, you can see here. This is an example. In normal lung, I'll go back. In normal lung, you are able to see these borders very well because this lung is very well ventilated. Hence, you're able to see these borders. So that we have to use that principle. And in case of pathology, say some pathology is sitting in the any of the lung, say right middle lobe, these borders are obliterated, and then this lesion is localized. We can say in this case, you can see this right heart border is not very well seen except for the lower portion. That means there is a pathology in the, I can localize this pathology to the right middle lobe. So the right middle lobe is in very close contact with the right heart border. So when there is a pathology, this gets obscured. That, I mean, this will tell us that there is pathology in the lung. And then conversely, if the border is retained, say suppose you see, I'll show this example. If the border is retained, the abnormality is superimposed. That means this may be either located anterior or posterior, not in same plane as that of the right heart border. If the lesion is located not in the same plane as that of the right heart border, the right heart border will not be silhouetted. So obliteration may occur with either any of the pathologies, mediastinal, pleural, or pulmonary pathologies. And then this is the classic example of pneumonia or consolidation in the right middle lobe that is obscuring the right. And the other is the lingular border is in close contact with the left heart border. So if you see any lingular pathology, so the left heart border will be obscured, and the apicoposterior segment lies close to the aortic arch. So if there's any pathology in this apicoposterior segment of the left upper lobe, if you see this aortic knob will be obliterated, and then the anterior segments of the right upper lobe and right middle lobe lie against the right aortic border as well. So sometimes this also, in this case, like in this case, you can see the right aortic border is also obscured. So another important sign is this hilum overlay sign. So in this case, This is to differentiate between the hilar and hilar/mediastinal masses from the heart mass or heart pathology. Like say suppose there's pleural effusion, pericardial effusion. So if it is a mediastinal mass, it overlies the hilum. I'll show the example. Whereas the cardiac pathology, like say large pericardial effusion, it will displace the hilar structures laterally. So in this case, look at this example. So that right, you can see this. There is a mass in the left hilum, right, and you can see the hilar structures through it. That means this mass is located either anterior or posterior to the hilum. So this is called a hilum overlay sign. Whereas if there is a large pericardial effusion, this will actually push the hilum laterally like that. So that is hilum overlay sign. So another important sign is this air bronchogram. You would have often heard this air bronchogram. This is exclusively seen with intrapulmonary pathology, and then this is commonly seen with either pneumonic consolidation or pulmonary edema, and this would be seen only if the bronchus is patent. If the proximal bronchus is patent, you would see this air bronchogram because the air column is patent. Hence, you would see it. Otherwise, if it is occluded totally, you may not see this. You may not see the air bronchogram at all. So, other causes would be atelectasis, severe interstitial pneumonia, interstitial disease, and neoplasm, especially post-obstructive consolidation and all may happen. And then that's where you can see the air bronchus. See here in this case, I'll show one more. Same patient, magged up image. You can see these lines here. So those are the air-filled bronchi. That is typical air bronchogram. In this patient, he came with fever and cough. You can see this homogeneous opacity here. The left hemidiaphragm is obscured. The left CP angle is also obscured. And then there is pleural effusion. So this is a classic case of some pneumonia, left lower lobe pneumonia with parapneumonic effusion. Okay, even sometimes there is atelectasis. So you may see the same findings. So you have to correlate with the clinical findings that the patient has got fever and all. So most probably you're dealing with pneumonic consolidation and treat accordingly. This is a different patient, CT view. This is how it looks. This is what is called as air bronchogram. The main bronchi are outlined, and whereas the rest of the lung is, it is kind of collapsed, opaque. And then the other commonly encountered entities, we would often hear this pneumonia, infiltrate, atelectasis on these radiographic descriptions. So again, as you know, the pneumonia is an airspace disease because of the bacterial or viral fungal infections. These spaces of the airspaces, what I talked about, the acinus and all, that is the airspace, alveoli, acinus. These are all, when they are filled with fluid, you see an opacity. Those are called airspace opacities. In case of pneumonia, these are filled with pus or a thick fluid. And the other this you cannot differentiate. Say you find an ill-defined opacity or airspace opacity in the lung. It could be because of a pneumonia, or it can be because of neoplastic process, or even the pulmonary hemorrhage and may look like inflammatory process like sarcoidosis can look like that. Even alveolar proteinosis, they all look same on the radiograph. That you got to be very careful. So hence the description is very important. You have to make your findings where the opacities are located based on that, and then you have to correlate with the clinical findings, and then you have to make a diagnosis. So, right, and then pneumonia will not cause a volume loss, whereas the atelectasis, I'll come to the difference a little later. How to differentiate between the pneumonia and atelectasis? They may look alike on the radiograph. There are features to differentiate between the both. So X-ray findings, you will have this airspace opacity, lobar involvement, or sometimes the interstitial opacities. So how do you differentiate these from a mass? So usually these masses are very well defined, whereas pneumonia very well defined. And then sometimes to confuse, you have this round pneumonia. There is an entity called round pneumonia where it may look like a mass. So hence you need to follow up those kind of lesions to make sure they are not neoplasms. And then depending on the type of pneumonia, so if there is lobar involvement, usually the pneumococcal pathology, and if it is a lobular involvement, often staphylococcal infections, and if it is interstitial, usually these viral pneumonias, they usually start off as an interstitial process, and then they go on to become these patchiopasties. And usually no air bronchograms are seen in these interstitial pneumonias. And then another common entity, aspiration pneumonia. This is because of the gravitational flow of the aspirated contents or incomplete clearance of these secretions, usually in these ICU patients or post anesthesia alcoholics, debilitated, demented patients. And this usually you'll have this anaerobic infection setting in there. And then some of the commonly diffuse pulmonary infections. So you see this diffuse opacity in both lungs. So we can think of this community acquired pneumonias or nosocomial if the patient is hospital based, or immunocompromised host in case of HIV and all. This is PCP will have a diffuse pattern. So when you see a diffuse pattern, think of these conditions. Then next, the atelectasis. Atelectasis is nothing but a collapse or incomplete expansion of a lung or a part of lung, usually caused by an endobronchial lesion, some obstruction such as a mucus plug in these asthmatic patients, or a tumor, or sometimes the extensive compression, whereas in case of these lymph nodes sitting in the hilar region, compressing on the bronchi and causes atelectasis. And more commonly, what we see is you see large effusions. So these will compress the adjacent lung. So that we call it as compressive atelectasis. And the unusual type is this. This is the chronic atelectasis, cicatricial atelectasis, and secondary to scarring, TB, or post radiation. See this chronic atelectasis, and this is how it looks. See this, fairly well defined, no air bronchogram. And then you can see only part of the right middle lobe is affected here. Sorry, only part of the right heart border is silhouetted. And on lateral, if you see that, this is located in the right middle lobe. The opacity is overlying the right middle lobe, right? And to compensate that, there is always this hyperinflation of the other lobes. You can see there is hyperinflation of the other lobes as evidenced by this. This is basically a right middle lobe atelectasis. You're seeing very homogeneous opacity. Okay, when unlike in consolidation, where in consolidation you will see this volume loss. And another example of the you can see there's pretty much homogeneous opacity here. And then you can see a hilar mass, irregular hilar mass. So probably a neoplasm sitting in here. And then on the lateral radiograph, if you see this, that is your oblique fissure on the left side. So that has moved forward. That means there is, because of the neoplasm sitting in the hilum, is compressing on the bronchi and the entire bronchus, basically left main stem bronchus or left upper lobe bronchus, that is causing collapse of the left upper lobe. So this, you have to look for this movement of these fissures to look for the atelectasis. So some of the major differences you can see, there's volume loss in the atelectasis, whereas no volume loss with pneumonias. And then associated ipsilateral shift because of the volume loss, there may be shift of the mediastinum, and whereas with pneumonias you won't see that. And then these are usually linear or wedge shaped with their apex at the hilum, whereas the pneumonias may not be so. And then air bronchograms, it's not specific, it can be seen in both pneumonia and atelectasis. So another entity, pulmonary edema, which is commonly seen, not commonly, especially in the cardiac patients, in the cardiac hospitals. You see this could be either cardiogenic or non-cardiogenic. So this is cardiogenic, and edema is because of the increased pulmonary capillary pressure, whereas non-cardiogenic due to increased capillary permeability or decreased plasma oncotic pressures. So the causes for the non-cardiogenic edema, you see this in drowsing, near drowning cases, or this inhaled toxins, or allergic alveolitis, uremia, and some of the aspiration, you can say altitude sickness. All this will cause These are all non-cardiogenic causes of the pulmonary edema, and that's a typical radiograph. You can see this typical description of reverse battering sign appearance. There's involvement of the central part of the lungs, and there is a relative sparing of the peripheral zones. That's very characteristic. Here you can see, in fact, you can see some air bronchograms here because of the, usually this would start as an interstitial process as linear lines in the perihilar regions, and it would progress to become like air space opacities like this. This may, if you do a CT, this would look like some sort of consolidation, subsegmental consolidation. So this is a typical X-ray. And another patient, you can see again patient in you can see the heart enlarged, and then you can see additional shadow here. That's the left atrial enlargement, right? And you can see the prominent markings here. So patient is in failure, so probably left heart failure. And then coming to this pediatric chest X-ray, chest radiographic interpretation. So this slide, I mean, you have to follow pretty much the same pattern. You have to follow. First, look for the trachea, any deviation, narrowing, or displacement, and then the most important thing is in children, there may be mild deviation of the trachea. This is extrathoracic part, maybe because of the expression or expression usually. So don't attach much importance to the mild tracheal deviation to the right. That is normal in either adults or children. And then if you see, anytime if you see this intrathoracic trachea being shifted, this is especially on the lateral radiograph, even in expiration, if you see that it is abnormal, always look for any mass compressing or displacing it. Look for the airway, say suppose this group, laryngobronchitis, laryngotracheal bronchitis. You can see that steeple sign, narrowing of the trachea. Look for all those. So in children, it is very important. Always start with the trachea. Look for any narrowing, deviation, and all sorts of stuff. And then next, move on to this mediastinum. More often than not, you see this thymic. We call it cardiothymic. Instead of calling it cardiomediastinal, you can call it cardiothymic silhouette. This is the typical appearance of sail sign, that is. And then if it is large enough, and these anterior ribs may impinge on it and give this wavy appearance, that is called wavy sign of Mulvey. And you look for that. That is a normal appearance. This is very, again, highly variable. You may see it on both sides. You can see on one side. So you have to pay attention to that. And then heart and mediastinum. Always the atrial and visceral situs should be established by inspection of the bronchial anatomy and position of the stomach bubble. Always look for the stomach bubble and look for the cardiac apex, look for the ascending aorta, descending aorta. And then because the right-sided aortic arch, these are commonly associated with congenital heart diseases. So hence, look for the position of the, see here, the expected arch is not there here, but it is on the other side. If that is the case, and look for the apex. Okay, there are a lot of combinations. If there is total situs inversus, the probability of congenital heart disease is high, and if it is just a right side aortic arch, only 5% of the patients will have a congenital heart disease, other associated congenital heart disease. So, and then regarding this pulmonary vascularity, normally the lateral third of the lung should not show any lung markings. For any reason, if you're seeing that, that means there is increased pulmonary flow, that is called pulmonary plethora. You can see that example here. This is a case of cardiomegaly is there, case of VSD. You see here the pulmonary markings are seen all the way to the periphery. That is called pulmonary plethora. And then non-visualization of pulmonary vessels more centrally. So if you're not able to see the pulmonary vessels in this mid zone, so if you divide this into 2-3 areas, this lateral, middle, and not seeing here, that means in this, like in this case, you can see this overall oligemia. The lungs look, little translucent. That is because of the this is a pulmonary hypertension with pulmonary oligemia. That's called pulmonary peripheral pruning. It is called as. So you look for these signs, and then other causes of, some of the causes for cardiomegaly or all this congenital heart disease, cardiomyopathies, and then pericardial effusions. In case of pericardial effusions, say very globular, very well-defined margins with a narrow pedicle, something like that. So that's, and then move on to this. More often than not, you have to compare. As I said, compare for the translucency of the lung. In these patients, in these pediatric patients, you may not obtain this accurate centering. So this will also give rise to sometimes the oblique positioning will give rise to this increased translucency on one side. So hence you got to be very careful. Make sure you're getting it right. So if you see any time and then the history of, when history suggests you of some sort of history of foreign body aspiration or something, inhalation or something like that. So always do this decubitus views. Whenever you do this, see this is the left decubitus view. When you do a left decubitus view, because of the pressure, this lung will always be smaller than the contralateral side. Repeat the same on the other side, right side. See what is happening? This distance remains the same. That means there is an obstruction here. So this is a foreign body aspiration case where this bronchus is obstructed. Hence this is hyperinflated. So further reading, the textbook by Felsen. It's like Bible for the radiologists who want to master this chest. Any questions? That will conclude the session. If you have any queries, email me at SRINI, sorry for the space, dot Meka at telradsol.com. Okay, SRINIVAS dot MEK at telradsol.com, TELRADSOL.com. Thank you.